Well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I am Executive Director of ASPI. Our purpose here is to educate individuals, and we are emphasizing the fact that we are not a anti-treatment organization, but an anti-unnecessary treatment. We are here to educate about the options regarding active surveillance. So, a couple of quick housekeeping measures. We're going to show a short video regarding the PROTECT trial, and we're going to hold all questions until after the video. You can submit questions in the chat box, which we will try to address after the video. You can also use the raise hand button from the bottom of your Zoom toolbar, and we'll try to call on you, time permitting. And again, please keep yourself muted during the meeting. The speakers joining us here today are generously donating their time, so we want to be respectful of that. As a reminder, we are not here to dispense with any medical advice. Nothing said during this meeting by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. Also, you do not need to feverishly take notes during the talk as it is being recorded and will be available on our website in approximately 1 week. You will get an email notifying you when it's ready. Also, you can subscribe to our YouTube channel, in which you will automatically be notified anytime a new video is posted there. Last item is watching the meeting. If you'll notice in the upper right corner of your Zoom window, there's a button that says View. When you click that, you can switch between the gallery view, which is everyone, or focus on the speaker. We highly recommend selecting speaker, which helps you focus on the topic at hand versus what someone in the audience is having for lunch or dinner, or maybe even breakfast. So without further ado, I'll turn the meeting over to Howard Walensky, the organizer of this meeting. So relax, enjoy the meeting, and I hope you'll leave a little bit smarter.
Howard, before you
Howard.
speak, I was going to insert a few words, and then
Okay.
I was going to introduce you. Is that all right?
Yeah.
Does that work? Okay. Well, first, I wanted to say this is a great honor to have Freddie Hamdy and Jenny Donovan show up. They were the ones that were responsible for the PROTECT T trial, which established that active surveillance was safe, and you would basically live as long if you chose active surveillance over either a radical prostatectomy or radiation. That was big news. And it really opened the floodgates to active surveillance. Had it not been for the PROTECT T trial, I'm not sure where active surveillance would have been. And we were actually rather honored to be the first to present this award to this kind of an award to them. We at Active Surveillance, actually, we're the only organization that I know of that's dedicated solely to trying to help you pioneers out there deal with your active surveillance jungle. And and right on this call, we have a lot of years with active surveillance. We have Bill with about 14 and Howard with 13 or 14, me with 20 years of active surveillance. And part of what I want to say to you this morning is that we we have all pretty much reached a place of peaceful vigilance in dealing with this. You know, when you were first diagnosed, you had this, see, I have cancer, and you had all this panic. And I know for 3 years, I lived in that place of panic 20 years ago because my dad had died of prostate cancer. And so I didn't even know that a thing like active surveillance existed back then. And part of our message is that you can be at peace with active surveillance. We call it peaceful vigilance. And you can get there. I began to tell a story for those folks who came early. And we usually, on these webinars, we usually try to let folks in 5-10 minutes early and chat with them. And so I began to tell a story about that I just had a PSA done. And my general practitioner asked me when she was ordering the blood test, she said, "Well, do you want a PSA?" And I had to think for a while because I'm 75 years old. Well, why do I need a PSA test? I'm not going to have any intervention, I don't think. But anyway, I got my PSA done. Well, and it came back. Your PSA is high, 9.7. It went up from about 6.9 to 9.7. But that didn't affect me at all because I knew that the PSA was pretty much meaningless. I knew that the important thing was PSA density, and that's one of the things that we have tried to encourage all of you actually to encourage your medical folks, whether they're urologists, whether they're your GP, to use prostate density. And all that you need is the PSA score. You put that, you divide that by your prostate size. And so in my case, my prostate score was 9.7. My prostate size was 75. So it came out to, that ratio came out to 0.13, which is below the magic number that they've assigned, 0.15. And supposedly, if you're below 0.15 in your prostate density, you shouldn't have to worry. So I gave no anxiety, no thought to that. Although I'm talking about it now, but this isn't a worried voice that you're hearing. This is just a story, a tale I'm telling you. And the thing that tests can do too, they can provoke anxiety, and anxiety will tend to release cortisol. Cortisol is a foundation for inflammation, and so much of our message at ASPI is how do you be peaceful with all of this? And you can be peaceful. All of you out there can be peaceful with living on active surveillance with prostate cancer. I remember when I was diagnosed 20 years ago.
Hey, Mark, I'm getting messages from our viewers saying it's time to move it along. So,
all right. Well, thank you for telling me that. That's why don't we roll the film then? No, let me introduce Howard Walensky, who has connected with Freddie and Jenny, and let's go ahead.
Okay, well, I'm going to be real brief. Doctors Freddie Hamdy and Jenny Donovan embarked on the Protect trial 25 years ago. They faced an uphill battle. They ran into disbelief that they could even do the trial, but they stuck with it. They made it happen. This landmark study of British patients showed that what they call active management compared favorably in terms of mortality to surgery and radiation. So in other words, people with on active maintenance didn't really need to be treated. They needed to be observed and then treated if their numbers spiked. Our speakers have prepared a video, which we're going to show immediately, and they're going to stick around for about an hour to ask questions. You can put questions into the chat room, and I'd say, Bill, let's go.
So what we would like to do is just give you a little bit of context, and we will share this presentation. So we'll do it in turn and give you context. And context goes back to the 1980s. And some of you will remember that. So the context for the 1980s is that there are three events which coincided together. The first one was the discovery of prostate-specific antigen testing in the late 70s, adopted in the 1980s for testing and for the diagnosis of early prostate cancer. What it did is it alarmed people for the possible presence of prostate cancer, but it didn't actually say that the patient had prostate cancer. In parallel, the biopsies of the prostate were evolving using transrectal ultrasound guided biopsies. When I was trained as a resident, we used to put the finger in the rectum with a glove, with a needle much bigger than the needle that's being used now, and guide the needle through the rectum into the prostate. This is how we did biopsies. And this obviously was a revolution at the time to be able to do it under image guidance, because you had to be really crafty and lucky not to biopsy your finger as well as the prostate when we did that. And the third one was the actual operation of radical prostatectomy, refined by Pat Walsh at Johns Hopkins, who popularized the operation, made it reproducible with skills which were transmissible across surgeons. So the diagnosis of prostate cancer exploded completely in the late 1980s and in the 90s. And the digital rectal examination was still the preferred way of feeling the prostate, testing the prostate, together with PSA. If you went out and did PSA on men between the age of 50 or 70, the bottom line is that you will find a diagnosis of cancer in 2 to 4% of the men tested. Now, this really produced a global challenge, not just in the UK, but everywhere. And that global challenge, you can see what that means on the left-hand side of that slide. You see blue bars and red bars. The blue bars are the incidence of prostate cancer, and this is a WHO graph. And the right side is how many men die of prostate cancer. These are the red bars. And if you go towards the south of the graph, in the developing world largely, you can see that the bars are small, but of almost equal size. And as you go further towards the west and the north of the globe, you can see that the blue bars are much bigger than the red bars. And what that means is that many more cancers with prostate cancer are being diagnosed compared to the number who actually die of the disease. And in England and Wales alone, in 1991, there were 34 radical prostatectomies performed by one surgeon in London. And as time goes, you can see the exponential increase in the number of radical prostatectomies because people were receiving PSA as opportunistic testing for prostate cancer. And the current rates were in 2019 reached a peak, 6,988 radical prostatectomies in England and Wales alone. And in 2023, a decline, and some of it, I hope, can be explained through the impact of the PROTECT trial. So all these together have created new problems and new dilemmas and a real challenge. And the introduction of these new terminologies for prostate cancer, which were over-detection of cancers which will not cause harm through the lifetime of a patient, over-treatment, because the word cancer causes a lot of anxiety and makes people go and receive treatment. They want to get rid of it. And under treatment, because we still see patients who die of prostate cancer despite everything. So a real challenge and problems. And the 1990s, therefore, were plagued with lack of evidence. And there was no evidence that PSA testing and treatment of localized prostate cancer improved survival and quality of life, irrespective of the Gleasons at the time. As you said, we were not as well informed about the value of the Gleasons as we are now. There was a the threat of an increasing burden to healthcare providers and society across the world, particularly in the Western Hemisphere, treatment options had never been compared previously. So patients were given advice about receiving radiotherapy or surgery, very often based on the biases of the treating physician. And Jenny and I actually published a paper on that back in 1999, which showed that the doctor who delivers a certain treatment will advocate that treatment for the patient, even if the evidence for the benefits of that treatment is not there. And finally, there was a profound lack of evidence of what is the trade-off between the cancer benefits and the side effects of treatments when they're given. This was not known, and patients therefore could not make the right and informed decisions. So we started to design this, what was perceived as a completely crazy project by our colleagues, to invite 100,000 men for PSA testing across 9 centers of the UK. And we anticipated that we would diagnose around 2,500 prostate cancers, and we would invite these men to be randomly assigned through a well-conducted randomized controlled trial into the 3 common options that were available for these patients: surgery with radical prostatectomy, open at the time, not robotic or minimally invasive, radical radiotherapy, or conservative management, which we didn't even have the terms active surveillance, as you said earlier, or active monitoring. So we started with this conception, and the primary endpoint was going to be how many men die of prostate cancer, with secondary endpoint of how many men die full stop, how many develop metastasis and disease progression, and most importantly is to address the issue of the trade-off. We decided, and this is, you know, Jenny's genius and expertise really, was to bring an amazing patient-reported outcomes piece of work so that every patient is evaluated. And when we tried to put this to funders, and as I may have said earlier, we tried for 5 years to get this funded, both in the UK, various funding bodies, and Europe as well. We repeatedly failed, and eventually we succeeded to attract the attention of NIHR, the National Institute of Health Research, through a Health Technology Assessment Board, who said, yeah, we're not quite convinced that you could do this. And this is largely because most of our colleagues said it is impossible to diagnose a patient who's healthy with prostate cancer and then to give him a random allocation of one arm which will have no treatment in it. It said, you're crazy, it is unethical, you shouldn't do it, and we don't think you will be able to do it. So NIHR saw the light, or HTA rather, because NIHR didn't exist at the time. And they said, yeah, okay, we like your ideas, but we don't think you can do it. So we want you to do a feasibility or a pilot study to demonstrate that you can do it. And if you do, then we'll think again. And I'll pass on to Jenny now to explain to you about the feasibility.
Okay, thanks. Yeah, so we set out with the feasibility study. We worked really hard. It was a 2-year study, as you can see, that was funded. And at the end of the first year, the funder wanted to know how we were getting on, because they really didn't expect us to be doing very well. And what we were able to show them at this review meeting was that we were able to go out into the community, that men would come in for PSA testing, get the diagnosis of prostate cancer, around 3% of them. We also had nurses running those clinics, and they did an absolutely brilliant job. But when it came to recruiting the men to the randomized trial, we were, like everybody thought, struggling. So we were trying to see if the men would come into the 3-arm trial, but actually those who were interested in the trial mostly wanted to come into the 2-arm trial, comparing the 2 radical treatment options. But actually most of the patients didn't want to come into the trial, and they said they wanted surgery. And so we could have been closed down at that point, but what we've done, because of my background as a social scientist, is we embedded into the study a lot of qualitative research to understand the recruitment process. And that was really that really involved the participants a great deal. So we interviewed quite a lot of the men. We interviewed the clinicians to see what their issues were about the design of the study. And uniquely, we audio recorded the appointments between the clinician explaining the trial and the patients listening to that. And we could hear both what was being said and how the men received what they were being described. There was a small number of men who did agree to take part in the trial, and funnily enough, they were all patients that Freddie had explained the trial to, because he was committed to it. He was the chief investigator. He had a balanced idea about these treatments, and he was explaining things in a balanced and reasonable way, but his colleagues not so much. And so we used this qualitative research to work out what was going on, and it was quite clear what was going on. So when we listened to the appointments, first of all, most of the urologists were describing surgery first. They always described surgery first in great detail with enthusiasm. They then described radiotherapy with slightly less enthusiasm and less detail. And sometimes they didn't even mention the conservative arm. They meant to, but they didn't quite get around to it, or they called it watchful waiting. And as Mark said earlier, I had a patient who sat with me and I said, what did you think of the trial then? And he said, well, I don't want that watchful waiting. That's where you watch and I die. And we thought, oh no, that wasn't our intention at all. We were doing repeated follow-up, regular monitoring. And so one of the patients said to me, well, why don't you call it monitoring? It's active monitoring. So that's where the name came from, the active monitoring name. And the patients and recruiters were struggling with lots of aspects of the trial, but we were able with these methods to actually do something about it. So we then went on to really think carefully about what the conservative option should be. We called it active monitoring. We spent a lot of time discussing it as a clinical group, exactly what we meant by that, because we didn't have repeat biopsies in it, unlike active surveillance. So we reconfigured the study around active monitoring. We made the recruiters explain active monitoring first, so they would actually do that well, and then they could explain they were more comfortable. So and then we put in place a lot of training for the recruiters to help them explain the study as Freddie was doing in a balanced way and addressing the difficulties and issues that some of the patients were having. We wrote all this up, of course, as in the usual way. So where would you go on? But what happened then was that after the feasibility study, we were able to show the funder that we could do this. We were able to recruit the men. The number who came in and agreed to be randomized, as you can see on the right-hand side, it went from 40% agreeing to take part through 50, 60, up to 70% by the end of that second year. So in that 1 year, we made all these changes and the study was suddenly possible. And the funder had to fund the rest of the study, and we recruited right the way through to 2009. So this is the trial recruitment as it finished. We were pretty well on target for what we said we'd do, and we randomized 1,643 men. They agreed to be randomized between active monitoring, as you see now in the green box, and surgery and radiotherapy across all these sites. So I'm now going to hand back to Freddie to talk about what the results were on the clinical side.
Thank you, Jenny. So just to remind me, the purpose of the study was to evaluate the comparative effectiveness of active monitoring versus surgery versus radiotherapy to see whether they made a difference in mortality. So we first published our 10-year outcomes in 2016. And 15-year median follow-up outcomes in 2023. So what did we find? Well, after 10 years, you can see here the prostate cancer specific survival graph. On this axis here, it's the probability of surviving prostate cancer. And on this axis here, it's the number of years, so up to 17 years here. But you can see that at 10 years, the three arms of the study, or the three groups, active monitoring, surgery, and radiotherapy, overlap completely. You cannot separate them. So at 10 years, we found that mortality from prostate cancer, irrespective of any of the treatment, was very low at about 1%, with no differences in treatment. And what we found at 15 years, that has not changed, except the mortality increased a little, so it went up to 3%, but we still have not seen a difference between the three arms. And when I use this graph now in the outpatient department in consultations to tell patients, I tell them, as long as they have low or intermediate, particularly favorable risk intermediate, I'll tell them your risk of or your chances of surviving this cancer over an average of 15 years from now is around 97%. And for them, it is a piece of good news. The second piece of good news is that there is no difference, and this happens irrespective of what you choose. So why do we bother talking to patients about treatment? Well, it's because of this slide here, which shows you, again, the difference between active monitoring, which is the dotted green line, which is now separated from the other two lines, which are superimposed still, surgery and radiotherapy. So what this one tells you is that at an average of 15 years, the risk of developing disease outside the prostate, metastasis, is in the region of 10%. But if you have treatment within 12 months from the diagnosis, that risk is reduced from 10% to 5%. Putting it in other words, it's 1 in 10 men who have a risk of developing this, but not dying of the cancer. And if they receive treatment, it becomes 1 in 20 men. It's not zero by treatment. And the reason it's not zero is because we are still not able to stratify men properly when they are diagnosed with prostate cancer. Now, what happens to men once they go into active monitoring? And this is within the context of the trial. What you can see here is the two lines at the top, the red one and the black one, which show men who received their treatments. Average 92% of all men received the treatment. Active monitoring, we see typically what's happening in the general community is that at 3 years, approximately 25% of men switch over to one of the radical treatments. At average 10 years, 50%, 55% receive treatment. But when we looked at 15 years, there's a surprisingly slow rise from 50% to 61%. Now, what does that mean? A number of things. The first one is that about 40% of men never received radical prostatectomy, never received a radical treatment. And 25% of all men never received the treatment at all for prostate cancer. And this is, again, another piece of good news. The other thing to emphasize also is that we're exploring, and Jenny's leading on this, why is it that men switched over from active monitoring to a radical treatment? And the reasons sometimes, or most of the time, are very subjective. And some of the reasons are the anxiety that is generated by the diagnosis of cancer and men being really anxious, not wanting to continue active monitoring, or the physician becoming nervous about it, sporadic increases in PSA. So we're analyzing all of this, and hopefully we'll have some more data to be able to present and talk about. Now, Jenny will tell you about the patient-reported outcomes, which allows us to make this, help patients to do this trade-off between the benefits that you've just seen and the side effects of the treatments.
Yes, thanks. So like the clinical outcomes, we were able to publish these patient-reported outcomes in the same journal at the same time, at the same period. The patient-reported outcomes were complete data for 6 years originally, and then 12 years that I'm able to show you here. So the men completed this quite long study questionnaire. I don't know if you remember it, Heathor, but it was quite a long questionnaire. And 85% of the men completed that every single year, which is quite incredible commitment. And we produce these charts from that. This is overall health-related quality of life. And what you can see on the axis on the left is the score or the percentage. And over time, you can see how the different groups line up. And you can see for these major aspects of physical and mental health, anxiety and depression, there's no difference really between the treatment groups. But there were differences in functional outcomes, as you all know. And this is the item on urinary leakage. So this is the percentage of men needing to use 1 or more pads per day. And you can see a very clear difference between the different groups. In the red, you see the surgery group. You see all of them started at 0 pads, but in the surgery group, you can see immediately after treatment, there's a great increase in the number wearing pads, and then their ability to hold urine improves a bit over time. But once you get out to 5 or 6 years, it then stays the same at around 20%, going up to 24% over time. And this is really important because most of the studies that have ever been done, the other observational studies, all stopped around year 2 or 3. And so it was assumed that the level of needing to use pads would reduce further, and it doesn't. It continues. The active monitoring, then you can see there's a slight increase in the use of pads, and that's because some of them changed to the radical treatment, not much effect in the radiotherapy arm. And of course, the impact of this on men varies. We interviewed quite a lot of men, and here's some quotes from them. One of the men said, "I still wear a small pad just in case, because you don't want to have a damp patch or an accident. So some pads are used for protection." But other men experience much more severe impact. This one, it really changed my life. I couldn't go anywhere. I'm always thinking, what if I wet myself? It's in the back of my mind. If I bend forward now without thinking too much, I still do leak. So these effects, it's really important to be able to balance off these effects and know what other patients' experiences are like. So sexual function, we also know is affected by the treatments. And again, you can see here, this is the item on erections firm enough for intercourse. You can see at the beginning, they all started at around the same level. But again, with treatment, you can see the surgery arm affected. They have immediate low sexual function. And there's a little recovery, but not much. And it stays at that low level throughout. The other groups, radiotherapy has a bit more of an improvement because they stop taking the hormones, but it's always a little better than in the surgery group. In the active monitoring group, you can see the decline over time with increasing age, and some of them switching to radical treatments. It's interesting that they all end up in the same place. So sadly, sexual function does decline over time to a low level, but you can see very different pathways to that because of the different treatments. And again, the impact can be variable. So one man said, you know, I've been married for 36 years and we've just got to the point now where we avoid the situation. You're so disappointed afterwards because it's never what it used to be. And another, knowing now that I might not ever have sex again, I try not to think about it because it does crack me up. And these quotes really bring home to you the importance of these issues. And they need to be taken into account before a man decides about treatment. So you're going to do the key messages, Freddie?
So what, just to summarize really the key messages from PROTECT so far, and remember, we're at 15-year median follow-up. We're hoping to go to 20-year median follow-up, which is going to be unblinded at the end of 2025 to see whether differences are still there. So the most important one is that the risk of dying from clinically localized prostate cancer for low and intermediate disease at 15 years from diagnosis, irrespective of treatment, is very low, 97% survival. The other finding, which we didn't discuss in detail today, is that even in men whose cancer spreads outside the prostate, they really can live a very long time and may well die from other causes than prostate cancer. And this is quite an interesting observation and phenomenon. The side effects of radical treatment can continue to affect some men's life very significantly, up to 12 years after treatment and possibly longer, and we still don't know. So what do these findings mean? Well, it means that men who are diagnosed can now take that time to assess the trade-off between the benefits and the harms of each treatment option. Men with low and intermediate risk disease can now seriously consider active surveillance monitoring safely. And the 20 years will help us to decide whether that effect will continue in the future. And the issues continue. So I just want to bring home here a very interesting observation and a paper which is not sufficiently cited from the SPCG4 trial, the Scandinavian randomized trial, comparing watchful waiting at the time, this is an older study than ours, 1989, it started and reported in 2002, compared with radical prostatectomy. And they looked at the long-term quality of life outcomes after surgery compared with watchful waiting. And they made this very, very interesting observation. You can see the bars, and you can see very clearly that when they compared the population of watchful waiting and radical prostatectomy with a matched cohort of men without the diagnosis of prostate cancer, what I realized is that it is not really the treatment that you deliver to the patient which damages the quality of life. It is the diagnosis of prostate cancer. And that's a real revelation, and not enough people pay attention to that. And what we really say is that every time a physician decides to put a needle in the prostate, he has the potential to give to the patient that he treats and biopsies the opportunity or the risk of having a new passport, and that is a prostate cancer passport, which is likely to change that patient's life forever. A few for good, but many with damaged quality of life and anxiety for the rest of their life. And this is something which is now gaining popularity, and we hope will continue to change practice across the world. We can't finish without thanking people. First, our funders, NIHR, which really had the vision to allow this study to continue for 25 years at the serious cost of £39 million, which funded all that effort over the years, which is being labeled as the most expensive study by NIHR.
So we'd really like to thank all the patients, of course, as the most important people in the study. And there's Ivor with us at the HTA celebratory meeting when you got to perform even more poems than you did today, which was lovely. And the picture on the lower part is the final participant who came in for a PSA test. You can see over 100,000 men actually had PSA tests.
So they've been at the heart, really, of our work. And here are the three culprits and brothers and sisters in arm. David Neal, who used to be my boss in Newcastle when I was there, and when the idea, he put Jenny and I in touch. We had our first coffee back in 1993, and we're always grateful for his partnership in the trial. The trial steering committee, International Trial Steering Committee, and I will point out to you Peter Albertson, who's in the back there, who's been an absolutely stellar member of that group, and I know that you've also awarded him a prize from your organization and patient group, and all these amazing investigators, nurses, physicians, radiotherapists, pathologists, administrators, trial coordinators in particular. And I do want to emphasize Athene Lane, who's been our amazing trial coordinator, without whom this trial would have been really, really difficult to complete and achieve. So we're humbled by the award, and we want to say you a really heartfelt thank you from both of us and on behalf of the whole PROTECT trial team. Thank you.
Well, thanks, Jenny and Freddie. And now we're going to open up to questions. I know Jeff is here. I don't know if Jeff is going to field some questions or if Bill is, but I can start off with some questions myself. One thing is you've gone 25 years or so with this. Is this going to go on forever, or you're going to wait till the last patient dies of natural causes, or what does the future hold for this study?
So at 10 years, when we looked at the first results, I thought we already would see a difference. I was, biased, despite everything we've been doing. I thought that we were going to show a difference with treatments. I was very surprised at 10 years. And at 15 years, I was completely, well, I was as certain as possible that the differences between patients who had received treatment and not in metastasis would translate into a difference in survival. And we still didn't find a difference. And we just don't know. We don't want to even guess what's going to happen at 20 years. And it may be at the end that men are just going to die of other things than of prostate cancer. And that will be very significant and transformational, because you have to weigh the treatment side effects and whether the trade-off is going to pay off at the end with a significant oncological outcome. So we will continue to follow up as long as possible, and preferably until either we start to see a difference or patients who are aging will continue to die, possibly of other things. So it's not stopping yet. 20 years is going to be quite critical.
I see. Now, I'm wondering too, I've read several studies that talked about men in relatively large numbers quitting active surveillance, say 5 years after being diagnosed. And it's like 50% at 5 years, 75% at 10 years. I mean, we have a number of people on this call, like Mark and me and Phil up in Canada. You know, we've 15, 20 years on active surveillance. But in your experience, do you have that many people quitting active surveillance without progression of the cancer?
So you remember that graph that we showed in the video? What we've seen is the same pattern as most other active surveillance cohorts anywhere. You know, Laurie Klotz in Canada has the same kind of observations. At about 3 years after active surveillance, about 25% of men, so that's 1 in 4, switch over to a radical treatment. At 10 years, average, it's 50%. At 15 years, it's not doubled, it's 60%. And one anecdote, it's an anecdotal observation, but we're looking into it, is that the longer, and you can observe that with a lot of people today in this meeting, the longer you stay on active surveillance, the more confident patients are that they can continue on it safely. And sometimes when I had discussions about them, with them to say, well, what do you think? And he said, look, I've been on active surveillance for 8 years now. I've been absolutely fine. You know, I don't want a treatment. So people do gain confidence. Why do they move over? We look into the causes, but I don't know if Jenny wants to say anything, but I think there's an element of anxiety from the patient and sometimes an element of anxiety from the treating physician as well. Jenny, do you want to say something about that?
Yes, yeah, it's interesting. I mean, we looked at this a bit. We haven't done the full analysis, but early on, some of the patients get anxious and change without the test results really showing much difference. But also the clinicians, if they order tests, then and a test shows a slightly aberrant result, then inevitably the anxiety rises in both the patient and the clinician. And so there's a kind of complicated interplay between those things, and a lot depends on how calm the doctor is in looking at those test results, whether they order another one or whether they react to that. So it is an interplay between those things. But yes, for sure, it changes over time, more likely to change because of progression as timing goes on.
We are better off now than when we were doing PROTECT because there is MRI imaging. So I know it's not been adopted completely in the US, but essentially before the diagnosis, before the biopsies, we have a baseline image of the prostate with MRI. Then the biopsies diagnose prostate cancer, and then if the patient is on active surveillance, most of the protocols suggest that they should have a follow-up imaging a year later. If there are changes in the MRI, then that triggers new biopsies. So the surveillance is able to pick up objective changes, which we were not able to do when we were running PROTECT. So I think we're in a better place now to monitor patients more safely.
You know, you bring up the international differences, and I'm going to, in most ways, as far as I can tell, in the UK, it's a better system for the patients. Fewer patients end up getting diagnosed with low risk or very low risk prostate cancer, which spares them from the anxiety and also the financial consequences, such as having insurance denied, at least in the United States. I'm not necessarily talking about health insurance, but life insurance, long-term care insurance. People can be turned down for it. But I want to flip this on you based on a question from Gary Samuels. Part of what he asks, he said, in an ideal world, if MRI was readily available and affordable, what are your thoughts about that being first line of protocol? And it is first line in UK, correct?
No, it's not. The PSA still is the first line.
Okay. Well, I meant to say after
yeah, PSA is still first line. There is a study which is about to start in the UK, which is also looking at the possibility of doing imaging first. The problem with imaging is it doesn't really give you the diagnosis of cancer, because even now, only 40 to 50% of men who go through imaging and then have a targeted biopsies have cancer. So MRI is better because it can target the biopsy towards the visible lesion. It's also helpful because there is some evidence which is emerging that visible lesions matter more than invisible lesions. So in other words, if you can see the cancer, it may be more important than if you don't see it, but there's more work that's needed.
Yeah, actually, I was going to ask you about that later. You're talking about invisible lesions.
Yes.
And so I don't know if the audience is generally familiar with that. I know the last couple of years there's been discussion, at least in professional circles, but this is something I plan to take on as a subject and talk to some of your colleagues in England about, and I've talked to Dr. Klotz about it. Maybe you can explain what invisible lesions are, and if they're define them, and if they're not visible, why
So,
they?
yeah,
Go ahead.
so you have to go back to the beginning of the 1980s, 90s. So the only thing we had was a PSA test and then transrectal ultrasound biopsies. And transrectal ultrasound is not a great imaging technique for the prostate. So it didn't actually wasn't able to identify the lesions in the same way that MRI does. So what we used to do is PSA was high. We would do a digital rectal examination, and then we would do systematic biopsies of the prostate. And we would do, initially it was sextant biopsies, 3 from each side of the gland. Then it was 10 biopsies, and then people started to talk about saturation biopsies, where they put lots and lots of needles, 40, 50, and people needed an anesthetic for that. So the bottom line is that most men who are aging will have foci of prostate cancer, which are not going to harm them during their lifetime. So if you keep putting needles in the prostate, you are going to find these cancers. And if these cancers are not visible and they're tiny and they are of very low risk, low Gleason's, these lesions, the patient does not need to know about them. So remember that slide I put about giving patients a cancer identity, a cancer ID. That is really, really important. And you mentioned some of the consequences of that, like for insurance. So invisible lesions, we used to call them T1C. So it's based on PSA and biopsies which show a focus of cancer. As time went on, we realized 2 things. First, that you could identify some lesions using MRI. And you could not only do that, but you could target these lesions so that the old way of doing systematic biopsies, i.e., if you, the prostate is like a small orange. If you put, we used to put needles, irrespective of what we see. The direction of travel is that we stop doing that and we only target the lesion which is visible on MRI. And this is how we are achieving a reduction in the diagnosis of invisible lesions, which are of very small risk and very low grade, which really no one wants to know about because it's just not going to cause you harm.
Well,
I don't know if that answers your question, but that's
yeah. Well, let me ask. Yeah. Well, let me share some praise from Don Kramer, who says he tends to hang his hat on the PROTECT study, at least to some degree, to continue on AS. And then he mentioned some forum that I'm not familiar with, where he was advised he was on a death watch. As I recall, Don is a 3+4. But
Howard,
yeah.
if I could just jump in very quickly on the anxiety subject. I would like to throw in one more variable that takes place that I've had personal experience with some men that I've talked to, and that's the family. Because the man might be very willing or half willing to be on active surveillance, want to go in that direction, and yet it's a member of the family that thinks they are crazy. And so they are exerting a fair amount of pressure on that person. And I've even heard this in phone calls with the family member in the background kind of yelling at them about, you're crazy and this sort of thing. So that's one more variable that can be a factor in why they decide to go for treatment.
I would add to that too, not to just to blame the family, but I would suggest that some of the urologists are anxiety carriers themselves. They're maybe a little bit nervous, not sure, and they spread some anxiety. And I don't know if Jeff is here, but Bill, if you want to join in, I wanted to point out another difference between US and UK. And this relates to Sir Christopher Hoy, who is Britain's most decorated Olympian cyclist. He said recently, and probably most of the audience will not be familiar with this, that he was told by his urologist that he had 2 to 4 years left to live because he had advanced prostate cancer. He's only 47 years old. His father and grandfather both had prostate cancer. So I'm wondering how, in the US at least, most of the guidelines would suggest if you have a family history or if you're a Black man, that you should start getting monitored, I think around age 45. I don't know if that would have made a difference to Chris Hoy, but I wonder what the guidelines are in the UK, and I wonder if cases like Hoy's kind of slip through the cracks.
So we are all, as urologists, very conscious, and that's the advice we give to patients. When we see a patient who comes and has prostate cancer, particularly less favorable prostate cancer, which is not a majority of patients, we ask them, first of all, about their family history. So brothers, father, first degree relatives. And there is a small proportion of prostate cancers which is hereditary. So it's passed through genes. And we advise the men to make their male children, their boys, aware of the fact that they have this diagnosis. And we recommend that they start to get tested, initially with a PSA, from the age of 40. The reason we say that is because we know that in some of the hereditary cases, even in relation to female members of the family with breast cancer, there is a link with 2 genes, the BRCA1 and BRCA1 and BRCA2 genes. And if the men have that mutation, they are more at risk of developing not just prostate cancer, but developing aggressive prostate cancer. And it is likely that this is what has happened with Chris, who probably has been carrying genes. It's not going to help him at this stage. These men can develop aggressive forms of disease. It is very interesting. Our observations in a PROTECT trial is that in some men who presented died very quickly, within 1-2 years, and they had all the treatments thrown at them. And remember, the age range was between 50 and 69. Now, my guess is that the treatments, in many instances, does not make a difference. Why? Because these men have in their prostate what we call features of lethality. And the difficulty we have is about finding these features of lethality early enough to initiate a treatment without the disease progressing. So I don't know if that answers the question, but there is a small minority of men who have a hereditary form and they develop it early and they need to be treated very aggressively. Some can be cured, but it's a tough form of the disease, but it's a very small proportion.
Okay, I have a question here sent in anonymously. Should prostate cancer recur after treatment, can it be evaluated with the same parameters, considerations as it was when initially diagnosed?
Yes, so it depends whether is this for men who are on active surveillance or is it for men who receive treatment?
This person I happen to personally know, and he's been treated.
Okay. So it depends what treatment you've had. So if you've had surgery and you had a radical prostatectomy, you are followed up very closely, repeat PSAs, and we usually consider that a PSA which does not go down below the level of 0.2 nanogram per milliliter, or a PSA that rises after having dropped to less than 0.01. If it rises up to 0.2, this is something that we call biochemical recurrence. So biochemical recurrence, which means that patient has no symptoms, there are no signs of anything happening, but the PSA is rising very, very slowly. And 0.2 nanogram is a very, very low proportion of PSA circulating. Now, in the last 5 years, we have new imaging techniques which have completely revolutionized how we diagnose disease recurrence. And that's by using PSMA, prostate-specific membrane antigen radioactive tests, so PET CT, and this is able, from the level of 0.2 nanogram, to pick up disease anywhere in the body, which is early recurrence. And then that disease can be treated depending on where it is, how much of it there is, and then patients can have what we call salvage treatments. This is for surgery. For radiotherapy, it's a little more complicated because the prostate is not removed in radiotherapy, so it continues to produce PSA. But there is a formula which we call the Phoenix formula, which tells us when a patient who's had radiotherapy is at risk of having developed recurrences, and is based on a PSA calculation. Then the same applies. We can use PSMA PETs. We can use MRIs as well to look at lymph node enlargement in addition to the PSMA PET. In the past, we used bone scans. PSMA is much more sensitive than bone scans these days.
Now, Mike from Denver asks, what do you say to critiques of the PROTECT study? Now, what are the major critiques or criticisms of the study, and what are your responses?
The first critique that we received is that, and there is a question in the chat that I've seen, whether the study sample was biased towards low-grade prostate cancer. And when we published our baseline data back in 2014, this is without analyzing outcomes, about 70, so 3/4 of the men had on biopsy low Gleason's, so Gleason 6. So at the time, one of the criticisms was that, well, the majority of your cohort is low risk. It's no surprise that you're not finding a difference with the treatment. So when we published the 15 years, we analyzed again, we stratified using the various tools which had emerged in that time. And what we found is that, in fact, it was 34%, up to 34% of men who had intermediate and high grade disease, and it was 66% who had low risk disease. So yes, we do have a lot of low risk disease, but we also do have a significant number of intermediate risk disease. More importantly than that also is our inclusion criteria in PROTECT was that the disease needed to be localized to the prostate, confined to the prostate. When we looked at our radical prostatectomy patients, we found that about a third of them had disease which had started to grow outside the prostate. So they were T3 disease. And because it's a randomized design, we expect that in each of the other arms, including the active surveillance and the radiotherapy arm, there is also a third of the men who have locally advanced disease. So what we would say is that despite the fact that we had some men with extracapsular disease, we still were not able to impact on survival, and there was no difference. So this is one of the criticisms. The second criticism that we had is the ethnic composition of the cohort. We cannot say very much in PROTECT about Black men, and that is simply because of the ethnic composition of the 9 cities where we conducted the study. We had 2% or less who were not of white background. I'm trying to remember what other. Jenny, can you help me there?
One, yeah,
yes,
another
yes.
one was that the treatments have changed since we did PROTECT, because we had mostly open prostatectomies, and now most of them are done with robot assistance. We had radiotherapy that was conformal, and now it's modulated, and various other brachytherapy and so on. And our active monitoring protocol didn't include rebiopsying. So those criticisms are quite interesting. I mean, in terms of the patient-reported outcomes in relation to the treatments, the side effects of the treatments, a number of cohorts were started in the US to evaluate the impact of the new treatment, so the robot-assisted and the modulated radiotherapy. And the results they produced were almost identical to the results that we produced. They only analysed them for 3 years, but they showed very similar impacts in terms of urinary leakage and erectile function and so on. So actually, that criticism, while valid, didn't affect the rates of the side effects. And the changes that have happened to active surveillance in relation to active monitoring would actually have made the results better for active monitoring. But even so, our results were very strong.
The one thing also was imaging. So we didn't have MRI.
Yes.
And so I think it is a fair point that if we had MRI available, the composition of our cohorts would have been different. And we would have had more intermediate risk disease than low risk disease, because most of the low risk disease will not have been biopsied. Having said that, when we looked, for example, at the men who received radical prostatectomy and who died, and they received all sorts of treatments, all of them were upgraded, and the majority were upstaged as well. So that shows the imperfection of the diagnostic pathway without MRI. Will it have stopped men from being randomized? I personally don't think so. So these are the kind of critiques, if you like, that we have been receiving. The other critique that we were receiving is that we were essentially advocating no treatment for anybody with prostate cancer, which is absolutely not true. We are not putting in question with our conclusions the need for men who have high-grade disease to be treated immediately. We cannot comment on high-grade disease because we had 2% only of our cohort who had Gleason grade group 4 and higher. So it's difficult to make any conclusions, but we are not disputing the fact, never have, that men with high-grade disease need to be treated.
Howard, there's a question from much earlier in the meeting I'd like to throw out. The question is, Dr. Ablin, founder of the PSA test, talks of the unreliability of the PSA test except after prostatectomy because of variables including prostate size, age, healthy prostate cells, etc. In an ideal world, if MRI was readily available and affordable, what are your thoughts of that being the first line of protocol?
So I think this is being investigated at the moment. I think multi-parametric MRI with an injection of contrast is time-consuming, it's expensive, and there are now groups who are looking at biparametric MRI, which is much faster. It takes only 10 minutes. And people are investigating whether this should be the first line of treatment. I think it is unlikely that we're going to be able to just use an imaging technique to decide whether we need to pursue the diagnostic pathway in that man. I think PSA is far from being perfect, but it does help. For example, I completely agree with Dr. Ablin, and in fact, we had been corresponding many years ago. There is work that has been done by Hans Lilia, who is a very renowned chemist, who discovered the various isotopes and forms of PSA in the 90s. And he and his colleagues measured baseline PSA at the age of 40, 50, and 60. And what they found is that if your PSA is very low at the age of 40, 50, or 60, even, and when I say low, I mean around 1 or less nanogram per ml, even if men develop prostate cancer, they are very unlikely to develop any form of aggressive prostate cancer. So PSA is not useless. PSA is actually pretty useful, but on its own, it is just not a good enough tumor marker. But we're very lucky to have PSA because I think at the end, it's going to be a number of things together. And we can see already what the addition of MRI has made in terms of precision, in terms of avoiding low risk, the diagnosis of low risk disease. There are other biomarkers which are being explored. And I just want to say one more thing, and that is the majority of effort are driven towards the screening and the pre-diagnostic phase of prostate cancer detection. And there is a little bit of a vacuum in the post-diagnostic space where when you do find a cancer, how can you really define that this cancer needs treatment? Everybody's talking about clinically significant disease with a Gleason grade group 2 and higher. We have evidence that many of the Gleason grade group 2 cancers behave in the same way as Gleason grade group 1. So it is a little bit, it is quite misleading actually to have this definition of clinically significant disease, which starts at Gleason grade group 2, and that needs to change. It will only change once we discover these molecular and other lethality features once the diagnosis of cancer is made.
Hey, Bill, here's a question from John Zogaria. At age 74 with PSA under 3 and low intermediate Gleason score, what tests at what intervals are best for monitoring?
So I will tell you what we do. what we do is we monitor the PSA on a regular basis. We have a baseline MRI. We repeat the MRI on a 12-monthly basis. We do not worry about PSA fluctuation. There are 3 patterns for a PSA in men who have prostate cancer and in men without prostate cancer, and that in men with early prostate cancer. One is that the PSA will remain stable. We don't worry about these patients. The PSA will fluctuate, so it will jump. Sometimes it doubles. As long as it comes down, it doesn't matter. PSA is not a cancer substance. We all produce PSA. Some of it leaks into the circulation. It goes up with ejaculation. It goes up when you do a lot of cycling. It goes up with an infection, so there are many reasons for the PSA to go up, and one should not panic just because there is a blip in the PSA as long as it comes down afterwards. Where we do observe very tightly is if there is a pattern of increase over time. And that's why the imaging also helps, because then you can compare your subsequent imaging with the baseline, and the PIRAD system is a nice system that the radiologists have designed, and they can compare if there was a visible lesion before, what is the size of that lesion? It was 3 millimeters before. Has it doubled? Has it increased in size? Or is it exactly the same? And then you put all this information together, and you then decide, is there a real risk that this disease is progressing? And if it is a possibility, then the ultimate test is to repeat the biopsies, because the biopsies will tell us whether this has changed. And not infrequently, you would repeat the biopsy in somebody who had only a few cores of cancer. You don't find any cancer at all. In other instances, the cancer has changed, and we find a higher grade. And then there is this constant dialogue and discussion between the treating clinician and the patient to decide, okay, what do we do next? The most important thing is not to panic when these things happen, because we know that prostate cancer is very slow growing, at least the majority of them.
A couple people are asking about those circumstances in which you would recommend PSMA testing.
Yes, so we have criteria for ordering or requesting PSMA tests. We do request them routinely if the Gleason grade group is 3 or higher. We do request them routinely if there is a PSA which is 20 nanogram or higher. We do request them if the disease on imaging and MRI appears to be growing outside the prostate. So all these patients we need to ascertain whether they have disease outside the prostate, whether it's in the lymph nodes, whether it's in the bones. The other thing that PSMA PET helps with when you do it in patients is it shows you how much the cancer glows inside the prostate. And combined with the MRI, it can be helpful to do staging as well.
Bill Napoli, I guess, asked for a comment on differences observed with different PSA measurement tests. He mentions Roche, Cobas, ECLIA versus Siemens, Intelica IM. Said in his experience, Siemens test gives significantly lower PSA values, different enough in different assessment of risk and treatment. And I want to throw in there too, I understand there's another approach using recommendations from the World Health Organization. So, who do you believe if you get such a dramatic difference in a PSA test?
So I don't know what happens in the US, but in the UK, there's a quality assurance and calibration of the PSA test so that the variations are not ridiculous. And because if you have a threshold in particular, if you say, I'm not going to be interested in investigating a patient with a PSA of less than 3 nanogram, and you have such a variation, well, what happens to the 2.9 and what happens to the 3.1 if there is this variation? So there's 2 things that we do in the UK. One is that if a primary care physician sends us patients with a PSA elevation, unless it's ridiculously elevated, and they have to tell us whether there are any circumstances which could have raised the PSA, like the patient had a urinary tract infection, we ask for a confirmatory PSA, where there are no other mitigations, and we demonstrate that the PSA is actually elevated above that threshold. The second thing is that calibration of all the tests which are available that hospitals use, and the chemistry labs, basically. It can be difficult when different manufacturers have different thresholds. It can be very confusing, absolutely. I think this quality assurance is important.
Yeah, Bill?
Well, there's another question that relates directly to that. Says if you change PSA methods, is it important to re-baseline the patient to avoid a different assessment? This is shown in the product labeling and is important that clinicians are made aware of this by the lab.
Yeah, absolutely. I think the mistake is, as you said, is to have one test by a manufacturer in a lab and then another test in another lab. I mean, I get patients that come to clinic and they've had, particularly the ones that have their tests outside the UK, and we always repeat them with our own tests to make sure that it is within the values that we are able to use to provide the right management or to recommend the right management for these patients. So it is a mistake to have, particularly in monitoring, is to have PSA measured in different labs by different brands. Absolutely.
Okay.
Howard, I forgot to say one thing about, you asked me the use of PSMA PET also for recurrent disease. I mentioned it earlier, but if men have had a prostatectomy and their PSA rises to 0.2 or higher, we recommend the PSMA PET to try and find out recurrent disease. I forgot to mention.
Okay, now Satbir Singh from Toronto asks, how significant is free PSA and its increase on a person on active surveillance without previous treatment?
Yeah, there is a lot of literature about free PSA. Free PSA is just a different isoform of PSA, comes in different molecular forms, and we do not use free forms of PSA. If people want to use the isoform, different isoforms of PSA, they use the 4-kallikrein test, which is available commercially. It's not reimbursed in the UK. I don't know if it's reimbursed in the US. And we do not use it routinely in the UK. We don't feel that it makes a lot of difference, so we don't use it.
I think that the prostate health index test, which was developed by the PHI test, which was developed by the original manufacturer PSA. I think free PSA is included in that. And that is reimbursed in the United States, but there's controversy over whether it's good for active surveillance or not.
Exactly.
Jeff McLennan is asking about views on AI in terms of biopsies and MRI reads.
So AI is moving fast, as we know, across the world, everywhere, and there are two areas where it's going to impact prostate cancer. One is in interpretation of biopsies and histopathology. So finding cancer at the moment is based on the eyes of a pathologist who is trained to look down the microscope. And they will look and find where there are features of cancer in the cells and in the glands. More recently, instead of looking down a microscope, this is now looking at a screen, because pathology slides now are being digitized. So pathologists are able to look at them on the screen, which actually is starting to make a difference, because A, it's easier to communicate, and B, it's a very fertile ground to use AI. And how AI is going to be helpful is in two ways with pathology. One is it has the potential, and we're doing some really exciting work here in Oxford, to identify patterns of recognition of not just the cancerous area, but areas which conventionally look benign by pathology, by conventional pathology, which if you really use AI and you go down to the very, very minute level and you do machine learning, you are likely to be able to find patterns of recognition which tell you more about the pathology itself. Also, if you put 6 pathologists in the same room and you ask them to look at the same slide and tell you what the Gleason is, many of them will have different views about it. So there is a potential for AI to put some order in this and to have a more uniform interpretation of the slide. So I think it has future with that. Is it going to replace pathologists? I don't think so, because AI is fed by pathological science, basically. So it does have legs. The other place is imaging and MRI. Again, variability of MRI interpretation depends on the expertise and the skills of the radiologist who looks at the scans. It depends on the quality of the machines. It depends on the Tesla, which is the magnet. Is it 3 Tesla? Is it 1.5 Tesla, etc.? So there are many variables which could affect the interpretation of the reading of the MRI. And again, AI could put some order into that and reduce the variability in interpretation of the AI, so that the targeting of the biopsies becomes more precise, and the interpretation of whether there is a lesion which is likely to be cancer or not cancer, again, is more precise. Is it going to replace the radiologist? No, I don't think so, because there will always be equivocal findings that need to be sorted with a very experienced set of eyes.
Yeah. Joe Grown, a mathematician from British Columbia, asks, well, he says he would love to see the data stratified by initial grade group. Is that available? Is that it?
There are some publications. I'll have to dig them out and send that. But it's all preliminary work. This is not just in prostate. This is in other cancers as well. And it's a generic set of skills. The direction of travel is that it can be superior. It has done so in breast cancer, and there was a big publication in Nature a few years ago, which showed that it was more accurate than human evaluation. So it is going to be the direction of travel, but we have to be very careful about utilizing that in the future, and there are particularly legal issues attached to it, because if AI is the sole responsible structure that diagnoses a cancer or not, then who's responsible at the end of the day? Who is accountable? Or missing a cancer.
Yeah, Bill.
There's a question here I'd like to get out. It's a pretty short one, but I think an important one. Does the presence of BPH distort PSA results, and how?
It can do, depending on the size. We know. So PSA is actually a very good test to predict how BPH is going to behave and whether the patient is likely to need treatment or is going to go into retention, urinary retention in the future. So definitely related to the size of the prostate. Yeah, absolutely. And it is part of the normal evaluation of any man with lower urinary tract symptoms. They need to have a PSA done, and it is helpful.
Well, I think we're almost there.
Yep.
I have a question here. I met Freddie back in 2018 at the prostate cancer. Sorry, not at PCRI, but actually at a major medical meeting. We were on a panel, and at the end, when the panel was done, we talked afterward, and he mentioned that he thought the future of active surveillance was going to be for the Gleason 7s. And I wonder, do you stand by that, or are we going to get better in diagnosis?
I do. I stand by that, and there's already evidence because now our national guidelines in the UK organization called NICE, which makes recommendation to the National Health Service about what we should do and gives guidelines for clinicians, suggests that in men who have Gleason grade group 2, active surveillance should be discussed also, particularly in the men who do not particularly want an active treatment. So I think this has largely been achieved through the data and the results that we've had in PROTECT. So I stand by it. I think there is going to be a line somewhere, whether the line is going to be related to disease volume, whether the line is going to be only 7, i.e. grade group 3, so more a predominance of Gleason grade 4 plus 3 equals 7. But you see, I will tell you one which is a passion of my personal research also, apart from the clinical trials, is that every time a man dies of prostate cancer, he has in his tissue and in his blood a little black box. It's the same black box as the flight recorders that when a plane crashes, everybody's desperate to find. And what we are not doing enough of is find these little black boxes which are in this material to try and understand what actually made the plane crash, what caused the death of that patient. And once we identify these lethality features, then we're going to be able to identify at a very early stage through a biopsy material whether the patient has bad disease or not, and through the liquid biopsies. And then we will be able to direct the right treatment towards them. So I'm very optimistic, but these things take time. And I think we've made a lot of progress, but we're not there.
Well, one follow-up that somebody threw in there was, I think you kind of hinted at when you were talking about liquid biopsies. What are your views, and how do you use liquid biopsies?
Post-diagnostic, we don't, apart from continuing to use PSA, but there are many biomarkers which are, if you press the button, do a Google search, and you put PSA biomarker, you are going to get in excess of 30,000 returns on that, all talking about PSA biomarkers. What do we use? Nothing which is spectacular. People talk about circulating tumor cells. People talk about circulating tumor DNA. People talk about various serum, other biomarkers. There will be a long list, but if you look at what's being used in clinical practice, which is making an impact, precious little, actually.
Howard, we're just about at the end of our time here, but I did see a question come in. Did we answer the question about those patients who went off AS in the PROTECT trial? What is the breakdown between anxiety versus progression?
I'll pass this to Jenny. Yeah.
Well, I mean, we know that 9% of them develop metastases. So that's the hardest endpoint that they will have changed treatment. There were another 20%, I think, Freddie, who had local progression, weren't there?
Yes.
So that the vast majority didn't have progression, but it becomes a complex interplay in the individual, because when they have test results which are raised but turn out to be negative, there's an anxiety that's provoked, which can make some men then change treatment. And we saw a lot of that in PROTECT. And of course, the PROTECT men didn't have the PROTECT results. You know, they didn't know that, they didn't have the confidence that we all have now from knowing that, you know, they were going to have equivalent mortality. They didn't know that. So inevitably we had some movement with anxiety on both the clinicians and the patient's part. But the hard endpoints are very clear. The metastasis rate was 9%, and the local progression was around 20%-ish.
Thanks, Jenny. So just to add to that, so yes, there's a small number of men who had hard evidence that the disease had progressed, but the majority of men, we didn't. And I'll give you two examples of two scenarios. You have a man who has a PSA of 4, and he's on active surveillance, it's all active monitoring, it's all very stable, and then the PSA jumps to 8. And he panics, and he goes and he sees the physician, and the physician tries to calm him down and says nothing. He said, look, I don't want this active monitoring anymore. I want you to treat my prostate. And, you know, he goes for a radical prostatectomy, prostate comes out, and it's not much difference than what was expected. So that patient would have still have been overtreated because of anxiety. This is on the patient side. Then you go on the physician side, and we have been doing, although now there's a recognition that digital rectal examination is of limited value. So a patient would have a digital rectal examination on baseline, and he would come back, and the physician would do the examination and say, I think your one side of your prostate has gone a little bit firm now. I'm really worried about that. I think you should have your prostate out. That's anxiety on the physician side, not on the patient side. Patient has his radical prostatectomy, cancer is contained, no adverse risks. Patient is probably overtreated. Do you see how, I mean, this is just humane interaction and dynamics between the patient, the diagnosis of prostate cancer, the fear, and the physician. And it's complex dynamics, and, you know, it's fascinating. But that's what happens in real life.
So if I can interject a question here that's related to this. So it strikes me that maybe there should be an anxiety hotline for Gleason's 3+4, where maybe Gleason's 3+4 would be available to talk somebody off the cliff.
Well, Mark, why don't you give everybody your phone number?
I'm not a 3+4. I'm a 3+3, so I'm blessed.
I think Jenny wanted to say something.
Yeah.
So I was just going to say, imaging as well can have an impact on that anxiety, because the imaging is done. There's a result that's questionable, so they have more imaging, and then it's clear, and so they're told there's no problem. But having had that worry, you know, you inevitably get more anxious. So, and the imaging increasingly picks up more and more, doesn't it, Freddie? So.
Yeah, I mean, it's improving because it's largely relying on objective things, and this is again where AI is going to help probably. But now anything which is PIRADS 3 or less, radiologists just do not worry about it because they don't think it's significant. So it's the PIRADS 4 and 5 which really are significant findings to worry about.
Well, and if I could just add very quickly, there's even the case when nothing is found in the MRI and there's still anxiety. There was a gentleman that I was talking to that got the MRI results back, and I said, hey, they couldn't find anything. And I said, well, you're celebrating. And he goes, well, I don't know. Maybe they missed something. I went, well, wait a minute. Wait, it doesn't work that way. So, you know, you've got an infinite number of variables here.
Yes, exactly. Yeah, absolutely right.
Well, maybe it's time to adjourn.
Yep.
Thanks to Jenny and Freddie. Double fold. Thank you.
Thank you for having us. Good luck to everyone.
Yes.
Keep spreading the word. Keep spreading the word.
Yes. And you're doing a fantastic job supporting all these men.
Absolutely.
You know, he needs support. It's a really important role that you have. So thanks very much.
Without you, I'm not sure we'd be here. So thank you.
Right.
Thank you.
Nice to see you all.
Bye.
Yeah, okay.
Bye now.
Bye now. Bye-bye.
Bye-bye.